small you look. Okay. PCOS. I have to give it a few seconds and see if anybody gets on. Look at you, little tiny human. I'm not sure. What does that mean? It's live now. Oh, somebody's on. Who is it? Can I click this? We're computer savvy.
I'm gonna have fun going back and watching this later.
Say hi, who's ever on? It's not showing me who it is. Is it supposed to show me who? I did. Hi, somebody. Doesn't it usually let me click it? Or hover? I'm not sure. Morghan goes over the ins and outs of PCOS.
And now
they're done.
You have to talk to them.
Pointless.
I don't know who it is.
It doesn't matter. You have to talk to them. Hey,
You
whoever
say,
you are.
"Hey, whoever you are."
I did that. Hey, whoever you are, let us know who's on.
And what questions you might have about PCOS or infertility, and we'll be happy to answer them.
Yeah. Or logging on later and letting us know what questions. Oh, she's watching us now over there.
If there are questions or things that you have in the back of your mind, or things that you've been wondering about in terms of PCOS, polycystic ovarian syndrome, or in terms of fertility and how women are affected by polycystic ovarian syndrome, we would love to answer them now in real time, or we could answer them if you want to post your questions and you post them after this live event. We could post answers or direct message you the answers to your very specific questions if you have them. But right now we're here and dedicated to answering whatever questions women might have.
All these people are at work, probably.
I know.
We're at work too.
We'll just start saying things about it. Tips.
How great Chinn is.
No. About PCOS, things that you would want people to watch later. And then if people pop on, you can answer their question.
Tell me about PCOS, Morghan.
What would you like to know about PCOS?
What kind of symptoms would I be experiencing if I was concerned about having PCOS?
Well, as with any condition that affects any group of human beings, there's data that we have that looks at groups of human beings, so hundreds of women, and what those women are likely to experience, but it doesn't necessarily mean that you would experience all of those things. In terms of things that are very common among women who are affected by PCOS, things that they might notice are related to the hormonal changes that happen as a result of the syndrome. And so you might notice that you're having to remove extra hair on your face, either on your cheeks or your upper lip, sometimes on your chin, or down even onto your neck. And you may notice the growth of kind of midline hair that's excessive or above what you would have been born with. So you may notice that you're getting increased hair growth on your face, on your body, and you're finding ways to manage that, because most people do, but you're noticing like, oh, there's more of it than there used to be. You may also notice the development of some acne or cystic lesions on your face, on your chest, on your back, sometimes for some women on their butts. And that's the result of those elevated male hormones, which happens when women have polycystic ovarian syndrome in relation to the underlying cause of polycystic ovarian syndrome, which is insulin resistance. Now, insulin we think of as a medication for diabetics, but it is, but it's also a hormone in our bodies, and it's a hormone that, if it's dysregulated, dysregulates all of the other hormones in our bodies. So for women who have polycystic ovarian syndrome, they actually don't have a problem with their ovaries. They have a problem with hormones that then impacts how their ovaries function. So you might notice facial hair, facial acne, body acne. You may also notice that you start getting really irregular, unpredictable periods. In fact, you may notice that you're skipping periods some months. Like some months you're waiting for it to come and it just doesn't. Nobody is going to complain about having.
I was just going to say, as great as that sounds, doesn't mean it's normal or good.
Or good. And one of the reasons that it's not good is that when women who have polycystic ovarian syndrome are skipping those periods or not having regular periods, what happens is that lining that would otherwise be expelled at the time of the period continues to grow and be stimulated because the body thinks it's preparing for an egg to come out of the ovary. And if that doesn't happen because of the underlying causes and the process of polycystic ovarian syndrome, that lining can build up and actually become cancerous. So you can grow cancer inside of that lining. So a lot of women who have PCOS are like, sweet, I don't have to have a period. Like, that's great. I get 3 a year. But really, if you're not getting a period at least every 3 months, you should see a provider so that we can assist you in getting that stuff out of your uterus, typically by inducing a period, tricking your body into thinking it's ovulated, the egg has come out, and then allow the lining that's built up inside of your uterus to kind of be expelled so it doesn't overgrow and become cancerous. But those are the biggest symptoms that many women will report. The other big symptom that many women will report is excessive weight gain. So women will notice, like, I'm suddenly out of my size 10 jeans, now I'm in a size 16, now I'm in a size 20, and it happens really rapidly and over kind of a small period of time. Typically be triggered in puberty, and then it'll just kind of add on over the course of the years until women have found, like, I've gained an amount of weight that's now much more difficult for me to lose. And women who have insulin resistance also tend to have more difficulty losing weight because of what's happening in their bodies, and they have a harder time maintaining a lower weight regardless of how they're exercising, and that's just because of how insulin resistance works in their body. The other thing that if you had polycystic ovarian syndrome you might find is that if you were trying for pregnancy, might have more difficulty getting pregnant, and that's just because of how those hormones are acting on your ovaries to allow the release of eggs or not. And if those eggs aren't being released, clearly it's going to be harder to get pregnant. So that would be something that you may notice or come in complaining of if you had polycystic ovarian syndrome.
If I had all those symptoms, does that mean that I have PCOS?
No. And for so you might come in and say, hey, I have acne, hey, I've gotten fat, hey, I'm growing some facial hair. It doesn't necessarily mean that you have polycystic ovarian syndrome. You may have polycystic ovarian syndrome that's causing those symptoms, but you may also have another condition going on. And that's part of why it's really important to not just look at people and say, oh, here's your clinical picture, so therefore you have this, and you should do what everybody else does, which is this, because your symptoms may actually be coming from a totally different condition. It's very important that each woman have her particular circumstance evaluated individually so that we can determine what the source of those symptoms would be. So if you came in with those things, we might think, oh, maybe that's what's going on, but we really do need to do some diagnostic testing to figure out if that actually is the case or if there's something else going on.
Tell me some of the things that women can have done to be able to be, clinically diagnosed with PCOS.
So there are basically 3 what's called Rotterdam criteria. So there was a group that got together and put together the criteria for diagnosing polycystic ovarian syndrome. And there are 3 of those criteria. So it's the Rotterdam group, which is over in Germany, and they put together these criteria. You have to have 2 of the 3 to be diagnosed with polycystic ovarian syndrome. So one of them is what's called hyperandrogenism, or elevated male hormones. And you can have those on lab tests, or you can have them with symptoms. So there are some women who have polycystic ovarian syndrome who don't have acne. They don't have hair overgrowth, or they think it's ethnically appropriate for them. So it's not something that they come in complaining of. But when we draw those levels, we find that those are very elevated. Now, if the levels are normal, but they're having a presentation of something that's clearly been a change in their body, those reference ranges are, again, based on thousands of people and not on the individuals. We're just getting a snapshot of what's happening in their body and not what's been happening over time. So even though the levels might look normal, it may also have been that their level was lower to begin with, and now it's creeped up quite high, and that's an abnormal level for them. So they could have blood tests looking at those androgens. One of the other criteria is the presence of what's called polycystic morphology in the ovaries, which just means that there are lots and lots of little cysts inside of the ovaries that are occurring because of the hormonal changes that are preventing the eggs from actually being released from the ovaries. And if you see those on an ultrasound, that's also one of the diagnostic criteria. So if you meet those 2 criteria, then you could say you have polycystic ovarian syndrome. The third criteria is having an irregular period without any other reason. So you do need to rule out any other things, and there are many that could cause women to have irregular periods. But if they just have an irregular period and they don't have another reason for it, and they have the polycystic morphology or the particular look on the ultrasound, then they have polycystic ovarian syndrome without their male hormones having to do anything. So they don't have to have acne, they don't have to have hair that's growing other places, they don't have to have weight gain. But if they have those ovaries on ultrasound and they are getting weird periods, but their periods are not coming from something else that's going on, then they have polycystic ovarian syndrome, and you know how to kind of go about treating that. By the same token, if they have weird periods without another reason, their ovaries look fine on the ultrasound, but they have elevated male hormones, then that's also consistent with polycystic ovarian syndrome. What we know is that there are many different tracks of polycystic ovarian syndrome and many different manifestations, and that you can't just say as an umbrella, this is what every woman with polycystic ovarian syndrome looks like, which is what a lot of providers will say. Hairy, fat, has acne, she has polycystic ovarian syndrome, but really there might be something else that's underlying that's going on. Or those women may be regularly menstruating and not have polycystic morphology on ultrasound, and so therefore not have polycystic ovarian syndrome.
So you guys have a question?
Oh, we were
I just
even.
wanted to interject.
Hi, Mom! Oh my gosh. Look how cute that is. Her knowledge is really what we need. Missed you both. We miss you.
Miss you, Ma.
Oh my
I
gosh.
want to see your babies.
I want to see those babies. I see them on Facebook.
Did you see the question from Nicole McDonald?
I don't.
Oh, it didn't pop up there yet.
I don't see it.
So Nicole McDonald asked, what are the chances one turns into a tumor?
A cyst on the ovary?
I'm not sure.
We'll just blanket it with that. If there's a cyst on your ovary that you're concerned about, the chances of it turning into a tumor.
Well, so it kind of depends. So the morphology that I'm talking about in terms of polycystic ovarian syndrome, what you would see on the ultrasound is not one individual tumor. What you would see is a whole series of little follicles that are being stimulated but are not being released from the ovary. So you would see lots and lots and lots of different cystic structures in the ovaries. Some of them, because those eggs are not being released, could grow and become a cyst. They would not necessarily become cancerous or malignant, and they would not necessarily turn into a tumor because the only thing that's in there is an egg and the fluid around it. So typically what happens is that fluid continues to grow, and then eventually this cyst pops, which is very painful, releases the fluid into your abdomen, and then sort of recedes or goes away. Typically, that will not turn into a cancerous or malignant tumor. Sometimes, though, those cysts, because you've got an egg in there, which could turn into a baby, right? Like that's half a baby. That egg can start to develop into little pieces of things, and you could develop what's called a dermoid tumor, which is not a cancerous tumor, even though we use the word tumor. It's just a solid mass on your ovary that typically does need to be surgically removed. Those dermoid tumors are also called teratomas, and they're really weird things. So they're created by the stem cells that are inside that egg, again, half a baby, which can turn into any body part. So typically you find inside those dermoid tumors weird things like hair, fatty tissue, sometimes fingernails, sometimes teeth. Like there are funny things that can be in those dermoid tumors. That happens fairly rarely, but that can develop if those eggs are not being released from those cystic pockets, which is one of the big underlying issues with polycystic ovarian syndrome, is that development of those cysts and then the persistence of those cysts because the hormones are not allowing the eggs to actually come out the way that they typically would in a normal cycle. Does that answer the question?
I don't know if you guys can see it on yours, but I'll keep updating you. Nicole McDonald says yes about a cyst turning into a tumor. That's what she's asking about. And then said, I have PCOS, but they believe one turned into a tumor.
So that would be something where you would want an evaluation, either with repeated ultrasounds to check and make sure that that does have a solid component or not. Typically, you don't want to do an ultrasound any more frequently than every 6 weeks. And if you do have PCOS, you want to try to get that PCOS under control so that those cysts don't continue to recur. And once it's under control, if that cyst is persistent and it's staying on your ovary and it's been there for at least 1 6-week period and it's potentially growing, then you should have an evaluation where somebody puts a little camera through your belly, goes in, looks at that cyst, and tells you exactly what it is. If there's any chance that it could have a solid component to it, it probably does need to be surgically removed and typically sent to pathology to ensure that there's nothing in it that could turn into malignancy. Most growths on women's ovaries are not cancer, but there's not a way to know that unless you take it off and send it to a pathologist to look at the actual cells that are inside of that cystic structure. And again, if it's fluid, it's just fluid, and the cyst pops when the provider goes in and takes a look at it, and then there's nothing left to be sent to pathology. But if there's a solid component to it, then that really should be removed and evaluated.
Two questions in one here that I think, you know, in the past 2 years I've worked in women's health, we have a lot of women who go to the ER for their pain because they have significant pain, and like you said, when there's cyst ruptures, there's a significant amount of pain there. What would you say are some maybe follow-up things that they can do at home to kind of help, or some treatment options that they have to kind of keep them out of the ER?
Before they go to the ER or after?
Let's do both.
Okay. So if you are somebody who tends to make cysts on your ovaries, first, we need to evaluate the reason for those cysts. So if those are recurrent cysts, if it's happened a lot, if you've had them pop, it is awful. It feels like your appendix is probably bursting. And the reason that it feels so terrible, like you must be dying, like it's awful, awful pain. The reason it feels so terrible is that around each of those eggs that's not being released grows a pocket of what's called follicular fluid, and that fluid is not something that's typically inside of our bellies. So our bellies have a membrane that covers up all of our guts called our peritoneum. It's what holds everything in, so it doesn't just flop out against our muscles, but it's a membrane that can get really irritated by anything, blood, weird fluid coming out of a place that, because there's not typically something inside of your stomach that's being irrigated across all of your guts, that membrane can get really irritated by the fluid that comes out when a cyst does rupture. And that fluid then irritates that membrane, and it feels like stabbing, agonizing pain at the site of rupture, and then it can kind of get diffused across the belly too. And what's causing the pain is the inflammation of that membrane. So in order to prevent the pain, we should prevent the cysts in the first place. If you're a person who has recurrent cysts or who has had this happen, then we probably need to evaluate to see if there's something that we can do to prevent you from forming the cysts in the first place. If it's polycystic ovarian syndrome, often women are given birth control pills and told, oh, that's good, that's going to treat your syndrome. It's not. It may prevent the cysts from recurring, but birth control pills do not treat polycystic ovarian syndrome. They are a Band-Aid that masks some of the symptoms, but many of the symptoms and the actual underlying disease process continues despite the hormonal pills that you've been put on. That just solves the problem with your ovaries. So what I would say is we should prevent them in the first place if they're happening and they're recurring. There's not really much that you can do once it ruptures to stop the pain, except try to take some anti-inflammatory medication. So something like ibuprofen, Aleve, which is naproxen, those are the two best medications. Or if you are in the ER, you can get a medication as an injection called Toradol, which will stop that inflammatory response in the peritoneum and really control the discomfort. And then once you go home, taking kind of around-the-clock anti-inflammatory pain medications will help manage the pain, and then utilizing heat as well will help with that inflammation. But there's not really anything that we can do unless we know what the underlying source of that cyst formation is. If it's polycystic ovarian syndrome, then I would say we need to treat the whole syndrome and not just the formation of the cyst in order to treat what is going on in the women's bodies. So polycystic ovarian syndrome causes problems that are totally unrelated to our reproductive parts and actually way more important, but we think of this as like a GYN problem, right? Like we think of it as like it's a fertility problem, and it can be, but it's also a much bigger problem for the course of women's lives because of what it puts them at risk for if they have uncontrolled polycystic ovarian syndrome. Does that make sense?
I think it makes sense.
Thanks for the question.
Yes, yes. What are some misconceptions you feel like women have about PCOS?
I think women are often told that they have a problem with their ovaries, and they don't really have any underlying problem with their ovaries. The ovarian cysts are a symptom of this syndrome, and the underlying cause of the syndrome, it tends to be insulin resistance. So once we correct that insulin resistance, their ovaries go back to normal because their hormones, the whole cycle of their hormones goes back to normal. And if we're able to correct that, then we can correct the PCOS. Their ovaries themselves are totally functional and fine. It's just the different stimulation that they're getting from abnormal levels of hormones in their bodies. So I think one of the big misconceptions that women have is, I have PCOS and so therefore I'm going to be fat. There's nothing I can do about it. I have PCOS and so therefore I'm going to have facial hair. There's nothing that I can do about it. I have PCOS and so therefore I'm infertile and cannot have children. There's nothing that I can do about it. And none of those things are true. So all of those things are things that can be addressed. And sometimes we can kill 3 birds with 1 stone. So we can get rid of all of the symptoms by treating that underlying condition.
And when a woman is diagnosed with PCOS and she's having a hard time getting pregnant, when it's treated correctly, what is the likelihood of her becoming pregnant in the future?
It depends on the treatment plan, and it depends. So I can give you statistics. What is the likelihood of 100 women becoming pregnant in a year? With treatment of their PCOS, most of those women would conceive within 6 months of beginning treatment. But I also don't know anything about the partner, where they're getting the other half of a baby, what's going on in their personal lives, or what's going on in the rest of their body. So we shouldn't, just with any condition, we shouldn't see PCOS as a siloed condition. And I don't like to see people as groups of people. I like to see people as individuals. So I don't like to give any 2 women the same exact treatment because their bodies are going to respond to it so differently. I like to treat, if I'm treating you for PCOS, I like to treat you for the PCOS that you have in your body and how it manifests in your body. And your goal might not be to get pregnant. Your goal might be to manage one of the symptoms, or your goal might be to prevent yourself from having a heart attack later in life, which happens much more often for women who have polycystic ovarian syndrome. Or you might want to treat the depression and anxiety that come with PCOS because of the abnormal hormonal levels. It kind of depends on what your goal is and what you're hoping for from the treatment. And then if it is truly fertility and you're like, I want to have a baby this year, that can happen, but your treatment regimen is going to look completely different from somebody else's who has the same condition because it's going to manifest differently in their body.
You're not all the same. You're not.
Hi, Megan Alder.
I was gonna say, hey, Megan.
We miss
Oh my
you.
gosh. Oh my gosh. Her kids are huge too now. Holy
Are they?
cow. Oh yeah. I see them all on
Yeah.
Facebook. So a lot of, like you said, a lot of providers will treat PCOS with just birth control. Like, here you go, here's birth control, carry on with your life. And that's like you said, a huge misconception of treatment of PCOS. So every woman who's complaining of symptoms who maybe has been diagnosed with PCOS, there's not one sure treatment plan for each of them. Every single one can have something very, very, very different.
Right. And I would also just caution women to not assume that PCOS is also happening in their body as a lone condition. I mean, many women have been seen and briefly worked up for PCOS or told that they have PCOS, and then they think that that's the source of their problems and that that's the only source. But I would say that every woman who's having fertility challenges should have a complete workup for infertility to make sure that there's not some other additional problem that's contributing. And I think the thing that's most often overlooked is actually a semen analysis if they have a male partner. So if they have a male partner and they don't know the quality of that sperm, they can't consistently, even though women will always blame themselves for everything, and men will always be like, no, my boys are fine. They will.
True.
We should always see everything holistically, right? Like we should take a full picture of what their fertility situation looks like and make sure that there's not something else that's contributing to infertility. I mean, even a very slight shift in their thyroid hormones can make it harder to get pregnant. And if we tell somebody you have PCOS and that's why you're not getting pregnant, but we neglect to work up everything else, I think we're really doing people a disservice, because we should take a complete picture and work with that complete picture. If we don't have all the pieces of the puzzle, we can't come up with the best solution.
You guys know Morghan and Dr. Chinn, and you guys all should know if you've seen them that they will never just take one diagnosis or one problem and just say, this is how we fix it. They will continue to kind of look at everything, and that's why we've developed Chinn to really change the way you women are treated and the way that your healthcare is taken.
I mean, it's just so important that everybody, not just women, but everybody have comprehensive care. And a lot of the problems that I see with the current health system and the way that people are treated when they come in for care is that people are treated as a specific condition. And we're going to address this specific condition today. And then the rest of their bodies, the rest of their lives, the rest of everything that might be contributing to this or to, preventing them from achieving their ultimate goal is kind of left by the wayside. And then patients are told, oh, well, you should come in for that separately. And they maybe see another provider, they see somebody different, somebody doesn't have the complete picture, and nobody's putting together all of those puzzle pieces. I think with PCOS, because it is a complicated syndrome and it does affect so many parts of women's bodies and lives, I think it's really important to have that complete puzzle and to have a consistent provider who's putting together that puzzle and then partnering with the woman to come up with a treatment plan that works for her and gets at the actual goals that she's developed for herself in her life. And I think the same is true of infertility. I mean, we should not approach infertility as a siloed condition that we attribute to one thing or another. We should really look at the whole picture of what's going on and then have a consistent provider who's walking that path with the woman or with the couple and helping them get to where they want to be, which shouldn't be the provider's decision. It should be the woman's decision.
And if you so choose to bring your care to Chinn and let us help you pave that road, then we would love to have you. We would love to have you.
Yes. What other questions might people have?
It's always funny when there's not like
I know.
immediate response.
There's a slight delay.
Yeah. I don't know if you're seeing more on the backside than we're seeing on the other side.
No more questions.
Okay.
Well, if questions do arise, or if you have questions that you think about after the fact, if we've kind of piqued your interest in PCOS or piqued your interest in infertility, if things come up and you have questions about, hey, is this happening in my body because of PCOS, or might I have PCOS, or what might it mean for me if I do have PCOS, either relating to your fertility or relating to your life in general, don't hesitate to just shoot us that question. You can add it on here, or you can send it to our main Facebook page as a direct message. We'll be happy to answer those questions for you.
You give us a call. You can always call us. And with some of those things that she was talking about that maybe are attributed with PCOS, maybe you're just having weight gain that you're concerned about, or maybe you're just having facial hair that you're concerned about, or maybe you're just having irregular periods that you're concerned about. We can work on those things too. Weight management here is fantastic, let me tell you. But yes, it's anything you guys need, you give us a call and we would love to have you in here.
Mm-hmm. All right, TGIF, it's Friday.
Oh, yeah.
Have a good
weekend.
Appointments if you need one.
That too.
Otherwise, have wonderful weekends, and we'll talk to you guys next week.
Bye, guys.
Bye.
Scene. Oh. Okay.